Hello, I'm Dr. Neil Skolnick. On behalf of CME Outfitters, I'd like to welcome and thank you for joining us for episode 2 of our 3-part series on REMS, the CMEOCast series. Today's episode is titled A Collaborative Approach to Pain, Working with Your Patients to Reach an Informed Pain Management Program. Today's activity is part of a series of risk evaluation and mitigation activities, or REMS education, covering the FDA blueprint, opioid analgesic REMS education blueprint for healthcare providers involved in the treatment and monitoring of patients with pain. REMS compliant education is a critical component of the ERLA opioid analgesic REMS program to provide education to clinicians on safe opioid practices, as well as current regulations and guidelines on treating pain and prescribing opioids appropriately. To meet the requirement for REMS, at the end of the activity, please complete the post-test and the evaluation to receive your CME CE credits. CME Outfitters will then submit your completed information to the FDA. It's that easy. Watch your email for additional REMS compliant education from CME Outfitters. Again, I'm Neil Skolnick. I'm a professor of family and community medicine at the Sidney Kimmel Medical College of Thomas Jefferson University and associate director of the Family Medicine Residency Program at Abington Jefferson Health. We have 2 learning objectives for this program. The first is to evaluate your clinical workflow for opioid prescribing and incorporate 2 best practices in order to optimize safe and competent prescribing while minimizing the potential for abuse and diversion. The second of our 2 objectives is we'll talk about the importance of educating our patients, creating an alliance with our patient about their pain in order to optimize safe, effective multimodal treatment management plans. The backdrop for our talk is that there are 50 million Americans who are living with chronic pain. Chronic pain is one of the most common reasons for patients presenting to our office. Not a surprise. 20 million Americans are living with severe chronic pain. All of this adds up to over $500 billion a year in direct medical costs, lost productivity, and support for their issues. It's important when we think about an approach to chronic pain that we don't just think about it with regard to medications. Chronic pain requires a multimodal approach and an individualized approach. And when we think about how to approach things in the office, we can think about the different areas that we address with patients as medications, behavioral therapies, physical modalities, and monitoring and education. Monitoring and education, of course, goes across all modalities. And when we think about medicines, and we'll look at this in a little more depth in a few minutes, we have a wide range of medicines that we can use for our patients. But medicines aren't enough, because as we talked about in our first webinar and podcast, there are multiple domains in which a patient experiences pain, and the input to pain is both on a biologic level, on a psychologic level, and on a social level. So therefore, an important component of our pain management strategy is behavioral medicine. Often, it's helpful to have a therapist involved who knows particularly CBT is the type of therapy for which there is the best evidence about decreasing pain and increasing function in our patients with pain. In addition, physical modalities and interventions. Interventions might be invasive interventions when they might be helpful based on our diagnostic assessment. An example, a patient with either bad knee arthritis with a flare who might benefit from a steroid injection, or patients with spinal stenosis or osteophytes pressing on nerves who might benefit from spinal injections. On the other hand, many patients don't need an invasive intervention, but are helped enormously by physical therapy and occupational therapy, or even home exercise programs are an area that has a lot of efficacy. Once we've put together that plan, What we want to do is make sure we follow up and have ongoing both monitoring. How are we doing? And again, we talked about this in more depth in our last episode. We want to clarify ahead of time what are the domains of function that matter to our patient, both personal, themselves, the people they care about, and at work. And say, how are we doing meeting those goals? Are you improving not just in the experience of pain, but also with regard to function? That's monitoring and education, giving clear expectations about what to expect and creating clear buy-in over time. Let's talk in a little more depth now about medications. So we have 7 different potential classes of medicines that are available to us, and we'll go through these each in a relatively concise fashion. 1, acetaminophen, works effectively to dampen pain, but it's not incredibly effective for severe pain. It's safe, it's well tolerated. We want to be aware of hepatic issues. We want to be aware of drug-drug interactions, particularly not well appreciated is an interaction with Coumadin, with warfarin. NSAIDs. NSAIDs really are often viewed as a go-to medicine. They're available over the counter, and they're viewed, in my opinion, kind of unfortunately, as very safe. In fact, I think most of us are well aware of the effects with regard to an increased likelihood of GI bleeds. Most, though not all of us, are aware of potential renal effects. And perhaps most importantly, even though there have been a box warning on all of the NSAIDs for about a decade now, I'm not sure it's as well appreciated that NSAIDs have significant cardiovascular effects and increase the likelihood of patients having MIs. This is important because NSAIDs are easy to use for acute pain. They're pretty safe with the caveats that we mentioned for our younger patients, but as we get to older patients, particularly those with multiple risk factors for heart disease or established heart disease, we want to be very thoughtful and careful about their use, because the longer you use them, the longer someone is at risk, at an increased risk for an adverse cardiovascular outcome associated with NSAID use. Anticonvulsants, things like gabapentin and pregabalin. Very effective for chronic pain and for central pain. Downsides, a reasonable amount of sedation can be associated with it. Again, part of our discussion with patients is alerting them to that fact and then seeing how they're doing. Some people have fantastic benefits with very little sedation. Other people experience a lot of sedation. We make these decisions with our patient by follow-up, monitoring, and listening and evaluating how a medicine is doing. Antidepressants. When we think about antidepressants, there are 2 aspects to antidepressants and their effect on pain. 1, depression is far more common in patients with pain than it is at the population at large. And approximately 20 to 25% of our patients with chronic pain also have depression. So when someone's depression is lifted, they have less pain. That's one aspect of the efficacy of antidepressants. The other aspect is a direct effect on nerve endings. And here we're talking about particularly the SNRIs. FDA approved is duloxetine. And so if we're going to pick an antidepressant for a patient with pain, often it makes sense to pick an antidepressant, an SNRI, that can have both an effect on the depression and a direct effect on dampening pain signals. Musculoskeletal agents, things like cyclobenzaprine, can be helpful, particularly with regard to decreasing muscle spasm that can be a secondary effect of the chronic pain signals. Anxiolytics, while it is on the map here for our treatment of pain, and while it is clear that anxiety syndromes are more common in patients with pain than in those who don't have pain, I think of this as an area that reminds me to be really cautious. I don't like thinking of anxiolytics as a direct treatment of pain, and in fact, the opposite, because patients with pain are often on multiple medicines, I often will try to avoid anxiolytics, particularly benzodiazepines. And if a patient is on an opioid analgesic, I do all I can to avoid mixing, as we'll talk about later, an opioid analgesic and a benzodiazepine, because that can increase the risk of adverse drug interactions and bad outcomes. That said, we live in a real world, and there are going to be some people who do need both medications. And then finally, opioid analgesics. Opioid analgesics are very effective for pain, although something that many of us don't recognize is that the studies supporting the use of opioid analgesics for pain have primarily been short-term studies. There are not good long-term studies showing that opioid analgesics are very effective for the long-term treatment of chronic pain. So we want to be careful in our use of opioid analgesics to try to restrict their use to short-term. And we'll talk more about this in a moment. There's an excellent resource that I highly recommend to people, which is the Department of Health recommendations regarding use of opioid analgesics, and that was published in the MMWR in 2016. Some of the things that this document says is, one, like we were just saying, when we think about opioid analgesics, they're very, very effective for management of acute pain, but we want to be careful to limit the duration of use and to start at a low dose. And duration of use in the MMWR document is recommended to be 3 days or less if possible. And they say rarely is more than 7 days needed. And the rationale for that is that often acute pain, post-surgical pain would be the most common example, but also other traumatic injuries that occur, really diminishes a lot over the first week, so that hopefully other less potent medications can be used. In addition, on the adverse effects side, the incidence of dependency goes up dramatically after 7 days of use. And I know that seems like a short period of time, but that is what the data suggests. Other things that this document informs us about is that we want to really be careful about assessing and reassessing the benefit versus risk as we reach 50 morphine milligram equivalents a day, and rarely should we need more than 90 MME a day for patients for chronic pain. And when we're in that transition period, moving from acute pain management on past 7 days, we really do want to see patients back and carefully assess whether or not ongoing use of opioid analgesics is appropriate and reassess that periodically with an openness to patients who are on chronic doses of opioids, assessing when it is time to think about tapering. That decision about tapering isn't unilateral. And in my experience, this is not a decision that you come to a conclusion in one visit. So this is usually a few visit long decision where first we introduce the idea, would this be a good idea to start thinking about tapering? Often patients are resistant because they have understandable fears. If they taper their opioid medicines, are they going to have a recrudescence of intense pain? How are they going to be able to function? They're finally helping out at home. Their relationships are good. They're working. What happens if we withdraw opioid therapy? And here's where I think it's really important to have those discussions about risk-benefit, both short and long term. And to be clear with patients that when we talk about tapering, we're not talking about a sudden taking away of medicine or even a sudden decrease in the dose. We're talking about slow, incremental dosage reductions over time, because this is a marathon, not a sprint, and we have our eye on the goal. Bruce Springsteen has a wonderful song called Eyes on the Prize, and that's what we really want to convey. We're not trying to do this in a month or two, but we're talking about slow, incremental tapering, slowing down the tapering if a patient is having difficulty with increased pain or having side effects from withdrawal of opioids, but yet being clear what our long-term goal is. Sometimes that tapering is accomplished over a few months, sometimes it can take a year, but often it's more achievable than both we and our patients initially think it is. Let's go on now to our second learning objective, which is educating patients about their pain in order to optimize safe and effective multimodal treatment plans. And this is where a partnership is important. I mentioned in our first podcast that the patient gets a vote. When we're figuring out what to do, this is a discussion. This is not just a prescriptive activity. This is not a unilateral algorithm as in CHF and COPD. Let's put these medicines on and let's assess how the patient's doing. This is a discussion with the patient about their goals, their areas, their domains of function, personal function with others, work are the most common domains, and deciding both what would be best, but also sometimes pushing patients a little bit in areas that clearly are a good idea and might be a little bit foreign. A common example is exercise. We know that exercise is beneficial in diminishing pain and improving function. Yet, if someone hasn't exercised in 20 or 30 years, that can be a very difficult task to think about beginning, particularly if you have pain when you're exercising. And this is where our advice about starting slow with small amounts and slowly increasing over time can be very helpful. So again, discussing with the patient what the goals are, discussing the best way to do that, and being aware of both what we have to offer with medicines in the office and what the more expanded team around us also has to offer. Utilizing a therapist to do CBT-based management, both of pain and improvement of function, utilizing our physical therapy colleagues, utilizing our exercise experts to help patients in that area. And so by coming up with these plans, not alone, but together with a patient, having clear domains of function with clear goals, improvement of personal relationships, improvement of doing activities at home and at work, and reviewing how we are doing meeting those goals, we can utilize both medicines, we can utilize therapy, CBT, we can utilize physical therapy, exercise, and alternative approaches like acupuncture, hypnosis, meditation to create a full plan that we can carry out with our patient. I thank you for joining us today for episode 2 of our 3-part REMS CMEOCast series, available in both webinar and podcast formats. To view additional episodes on pain management, please visit CMEOutfitters.com. Please also visit the Opioid Education Hub. You'll find other REMS activities, as well as a broad range of educational activities and resources for healthcare providers and patients. As a reminder, to meet the requirement for REMS, please remember to complete the post-test and the evaluation so that you receive your CME credits or CE credits. CME Outfitters will then submit your completed information to the FDA. We hope that this has been useful for you, and I'm Dr. Neil Skolnick for CME Outfitters. Thank you.